It's nice kiss.
I'm going to start us off.
I didn't mean that.
So I'd like to welcome everyone. Thank you so much for coming to tonight's panel discussion on the changing face of healthcare in our community. We're so glad that you're here. This promises to be a great evening. We hold sessions every month on different issues that affect our community. Next month, Robert Espier will be chairing an event on a panel discussion on domestic violence, so we hope to see you next month. We meet on the fourth Tuesday of every month. Audrey Isaac is chairing this session and has put together an amazing group of panelists, so we're really looking forward to the discussion. In terms of the format, the first thing that we're going to do is just go around the table and introduce ourselves so that you know who we are as a committee and who the panelists are. And then we'll take about an hour to an hour and a half to discuss the questions that are listed on the flyer that you have. And we'll hold comments from committee members, board members, and the audience until after the panelists have a chance to answer the questions. So for the first hour, hour and a half, we'll hear from them, and then we'll open it up to a broader discussion. And it should be really great. So thank you, Audrey. And we'll just go around the table and introduce ourselves very briefly.
Noah Johnson, I'm committee member.
I'm Catherine, co-chair.
Nancy Rosenberg, co-chair. Fern Fleckman, community committee member. Fern Fleckman, community committee member.
I'm John Swartz, I'm the Chief Medical Officer at the Ryan Network.
I'm Adam Kurtz, General Counsel of Heritage Health and Housing.
I'm Assemblyman Dick Gottfried. I represent a little piece of Board 7, and I chair the Health Committee in the Assembly.
Hi, I'm Audrey Isaacs. It's my turn this month, and that's how it happened that we organized this program.
I am David Alge. I'm the Senior Vice President at New York Presbyterian for Community and Population Health.
I'm Robert Espier, several other pronunciations, and I'm a member of the
Shelley Fine, member of the committee.
Crystal Cordova, member of the committee.
Sonia Garcia, member of the committee.
Are you in the audience or no? Okay. Okay. So basically, we've got panelists who are in government, panelists who provide healthcare to low-income patients, and we have a representative of the New York Presbyterian system. So we wanted to have a balanced discussion of healthcare issues. So if you're speaking, all right. Now the first question I'm going to address to Assemblymember Gottfried first, which is what are the changes in the way the healthcare system is addressing the needs of persons who qualify for Medicaid, Medicare, patients who are uninsured, or patients with low incomes. And I just want to note that Senator Espaillat is coming tonight, but he has another meeting, so he should be here at approximately 7:30. So, Assemblymember Gottfried, would you mind addressing that question?
Well, New York State has been and is doing several things relating particularly to low-income New Yorkers. When the Affordable Care Act was enacted and other states were debating whether to expand Medicaid to take advantage of the Affordable Care Act, in New York, it wasn't even a topic of discussion, not because we weren't going to do it, but because for many segments of the population, we had already expanded Medicaid beyond the Affordable Care Act levels, number one, and number two, everyone just assumed in New York that if the federal government is offering money, we're going to take it. You don't have to call us twice for dinner here in New York. And so we did that, and we are also one of, I think there's only 2 states that have taken advantage of the federal option in the ACA that is called the Basic Health Program. In New York, we've called it the Essential Plan, not my idea. Enacting it was my idea, but the name was not. And what that does is it provides state subsidies for people who are above the Medicaid level, but at the fairly low income level of the Affordable Care Act. So they not only get their Affordable Care Act subsidy, but New York basically pays almost all of their share of the cost. It turns out, and it took some teaching to convince the health department and the Division of Budget of this, but that is a money-making idea for New York because we have for many years been paying at state expense for Medicaid coverage for a couple of 100,000 immigrants who are not eligible for federal Medicaid money, but we were covering them in New York. Because of the way the federal the basic health plan language is written, those immigrants are eligible for federal financial support under the basic health program. So by moving all of them into the basic health program, we are actually drawing down about, I think it's $700 million a year net profit from the federal government for enrolling those folks into the basic health program. Like I said, you don't have to invite us twice to dinner. We're there. We are reorganizing the Medicaid program to try to move Medicaid providers into integrated networks called performing provider systems. Again, a name that was not my idea. To try to hold down, particularly reduce hospitalization and provide better quality of care and more coordinated care, saving money. So those are the main things I think that New York is doing for low-income New Yorkers. What I hope to talk about it in response to several of the questions is what we ought to be doing for the rest of New Yorkers, because while the Affordable Care Act has made a lot of improvements nationally, many of them were enacted in New York 20 years ago, and they all still leave us in the hands of insurance companies, and there's a long list of headaches that leaves us with.
Okay. Dr. Swartz, do you care to comment on this issue?
Thank you. So I'm a primary care physician. I'm a family medicine doctor by training, and I've been seeing patients and carrying out leadership roles for over 30 years in Bronx and Manhattan. For me, I think that the last 5 years have seen a lot of improvements in Medicaid. I think we are moving in a much more positive direction than the majority of my career. And that's based on a couple of different things. One is we are now beginning to invest in quality. So we are, as providers, being rewarded financially for providing a higher quality of care. That allows our organizations to invest in quality. Historically, we've been paid for face-to-face doctor visits. And of course, with economic pressures over the years, lots of face-to-face doctor visits that we all felt were too brief. To really provide quality of care, we need to outreach to people who aren't coming into care. We need to educate our patients. We need to make sure that they have smooth hospital to home when they're admitted. And so the investment that Medicaid, through the managed care organizations, are making in quality are allowing us to invest in those things. And I think the future looks equally bright. Medicaid reform, the DSRIP program, eventually will put more and more dollars in investing in our ability to keep people healthy and to provide a high quality of care. So for us, from my perspective, this has been a very good time.
Mr. Herbst, do you care to comment?
Absolutely. Thank you. So my name is Adam Herbst. I am the General Counsel for Heritage Health and Housing, which is a federally qualified health center. Essentially, a federally qualified health center is a community health center that acts as a safety net provider in the community. We are on the ground, and part of our rules require us to have board members serve as the majority of our organization, which really, in a sense, is making us have our community activists be the leaders of our organization. Very different than other types of non-federally qualified health centers. And that is the changing phase. We talk about the changing phase of healthcare. Quite a bit of what the Affordable Care Act and what DSRIP is trying to do with Medicaid expansion is effectively do what federally qualified health centers have done for the last 40 years. What we have done is we have integrated behavioral health and preventative health. And to combine those two, we're really working as a primary care provider that offers different types of services on the ground. And we are trying to get people who would not otherwise be able to get health care, give them the access that they would have at preventative care, behavioral care, and try to get them out of the emergency rooms. To be able to do that requires us to be really on the ground. And that is how the changing face of healthcare has been really evolving under the Affordable Care Act. I also agree, Dr. Schwartz, that this is a good time for healthcare, specifically in New York State. Certainly there are changes that still need to be implemented, but the way things are rolling out at the state level has meant a lot of good for the people who would not otherwise be able to receive the care and would not be utilizing our services across the state. Get people out of the emergency rooms, try to get them the services before they need this type of care. And that's what we're seeing right now.
Mr. Algie, I'd like you to say whatever it is you want to speak about. But in addition, could you address the issue of whether or not hospitals in New York City are turning away from the low-income patients for financial trading on wealthier patients and patients who can either pay cash or can pay the delta between what the insurance companies pay and the actual bills?
So I think I just want to start first with, people probably don't know that New York Presbyterian is the third largest Medicaid provider in the state of New York. More than 38,000 Medicaid discharges, 127,000 Medicaid ED visits, and 450,000 Medicaid clinic visits. So I think, So I think that just want to sort of establish that as the thinking point. So I can't speak for the hospital industry as a whole. I can only speak for New York Presbyterian, and New York Presbyterian is seeing more Medicaid patients this year than we saw last year. So I wouldn't say that that's our approach. We are very committed. I mean, I think there's three things our CEO constantly says: we exist for the public good. So that's part of our mission, and that's what we'll do. I'm responsible for managing 14 primary care centers and 50 specialty clinics. Overwhelmingly Medicare, Medicaid, and the uninsured. That's who we care for in those clinics. So that would be New York Presbyterian's perspective on that. Can I just take a little bit also to go back to the first question of how I think things are changing? I think there's a growing consciousness, I think it's existed for a while, of the issue they call social determinants of health, of all the other things outside of a physician's office or a practice that influence how people access healthcare or what their concerns are, be it housing insecurity, food insecurity, transportation issues. And I think the DSRIP, the state program, and the ACO, where an ACO is a Medicare program, is starting to allow the flexibility to providers to move money around to sort of help people address those issues. Just tell one story. So I think that's an example of that. We have a 25-year-old woman in our clinic system who's diabetic, she's not really engaged in care, and has housing issues, she's got vermin infestation at home, she has 3 kids, she has a 10-month-old that has really significant health issues, it's congenital heart issues when he was born. So we assigned care management. Care management was something that we could do because of our district program that was a resource for us to do that. Did consistent outreach on the phone, convince the woman to re-engage in both her health care and her psychiatric care because they go hand in hand, obviously. Agreed to meet. She came to her first primary care visit, so there was a plan and a path going forward, and just really worked to engage that woman. Legal aid referral to help with housing court for the vermin infestation. So all around, the doctor's visit is really where we can start to provide support. And I think that's really what I see is a real change, I think, in the delivery of healthcare.
All right, it appears to me that you, as panelists, have already addressed the next 2 questions. So I will give you the opportunity, if you feel you have not had a chance to address them, to make comments. But what are the driving forces behind these changes, and how are these changes affecting access, quality of care, outcomes, patient satisfaction, and cost of care delivery? If you feel that there's something you want to add to those topics that have not already been said, please let me know. Otherwise, we'll move on to the next question. Anything else you want to say on those topics? No?
Spend all day on it. Yeah.
Okay. All right, so let's move to the next question. Can costs of providing care be reduced without negatively impacting quality of care? On that, I'm going to start with the assembly member and then go from panelists.
I think they certainly can be, and if not the cost of an individual procedure, to the extent we move people towards more primary and preventive care, rather than waiting till their condition takes them to a specialist or an inpatient bed, yes, we can keep people healthier and reduce costs. And that's what is driving a lot of the reorganizing that's going on. Part of the question really is to what is that there are a lot of ways to hold down spending, which is different from costs, to hold down spending in ways that do hurt people. And to me, that depends a lot on who is making those changes and what master are they serving. You know, a given payment system, let's say moving towards rewarding something that says it is rewarding quality rather than volume. To the extent that system can certainly be designed in a way that treats healthcare providers fairly and really does reward them for treating their patients better and fairly. If it's an insurance company designing that payment system whose mission in life is returning a maximum return to their stockholders, then a given concept of payment reform is in fact going to be designed and run in a way that screws providers and patients. And so to me, the thing you always need to look out for in any description of a reform system is who is it being designed by and for whose benefit.
Dr. Schwartz.
Yeah, so my answer is unequivocally yes. We can improve quality and lower costs. I've been at the Ryan Network only since last June, and we're well on the way, I think, to doing that. We've received some support from the state in the form of the hospital medical home project a few years back that allowed us to begin care management and begin lowering readmission rates for our patients who had been in the hospital. My previous experience in another organization, we were very successful at both improving quality and lowering hospital utilization by using care management and focusing more on our quality. And just to give you a very sort of basic example, in my previous life as a practitioner, the day was zooming through as many patients as I can. I didn't know what was happening to my patients when they weren't in my office. And frankly, I was too busy to be very concerned about it. I was just trying to get through my day. In the new world that I experienced, I now have a daily report coming from the hospital telling me who was in the hospital. I have access to those records electronically. I can see what's happening in the hospital. And I had an experience a few months ago where I was not happy with what the patient was discharged on. This was a patient with congestive heart failure where the heart is not pumping adequately. They build up fluid in their body, ultimately have difficulty breathing. And now I had a nurse who I could say, please call this patient. I don't want to see them in a week. I want to see them tomorrow. They came in 2 or 3 days after their hospitalization. They'd already gained 5 pounds of fluid, and I was able to intervene and keep them out of the hospital. So yes, that saves a lot of money, but for that patient and that family, it's not really very pleasant to get out of the hospital and have to rush back in 2 days because you can't breathe. Hospitals are not fun places to be. So I would say unequivocally that it is possible to do that. We need to organize and fund the system that allows me to practice in that way. And I think, we're certainly headed that way in the Ryan Network, working with Mount Sinai as our district partner.
Mr. Herbst, can you address the issue of when qualified health centers are uniquely able to costs and have a good impact on quality?
So like I said initially, federally qualified health centers, FQHCs, have for many years really integrated. We see vertical integration going up right now across the state, across the country. FQHCs are vertically integrated the way we offer care. Like I mentioned, we integrated behavioral health with primary health, with dental care. And a unique aspect of what we also have done is we've created affordable and supportive housing as well. So what we have really essentially done is we've looked at the entire patient. We see this new movement across the country to have ACOs, to have health homes. So we can look at the entire patient and not just look at portions of a patient. But we can look at a person, they have some type of ailment, whether it's a mental health issue, and that leads to physical health issues. We can get ahead of that, get them out of the ER because of one ailment. They really are acting proactively instead of reactionary. And that is really going towards what the Assembly member mentioned in terms of the new New York State initiative. And it is what makes FQHCs very unique. The fact that we have integrated behavioral health allows our psychiatrists and our primary care doctors to speak in the same building and speak within the same hour. That one particular patient has some type of mental health issue. Can we get that person on the right medication? If we allow taking 16 different types of drugs, they can speak to each other. That is proactive health. And that is how our really Affordable Care Act is changing the face of healthcare across the country. And that's what makes FQHCs unique. And that's also how today the mayor made a statement in terms of trying to get more community-based health centers out there. We're trying to get less inpatient, more outpatient type of health. That's exactly what we do at the FQHC level.
Dr. Schwartz, can you address the same issue, please?
Yes, so actually many of you in the room know that Fern Fleckman runs our mental health units at Ryan, and we have both a community mental health center, what's called an Article 31, for people with serious and persistent mental illness, as well as mental health integrated into our primary care sites. And I don't think anybody to hear that if you are a low-income patient, that it's not easy to get mental health services. Places have waiting lists to be able to even get in and get an intake. And I think one of the positive changes that are going on now is that as we begin to integrate more of mental health services into primary care, it's making it more available to our patients in a setting that they're comfortable in, and we're able to address very common problems like depression and anxiety in a way that we often weren't in the past. The primary care provider wasn't capable of doing it on their own. Patients often would feel they didn't want to go to a community mental health center. So we're really extending our reach. And we've seen as this movement has begun that is also allowing patients to take better care of their physical health. So many diabetics who are out of control, partially because they have untreated depression, when you treat the depression, all of a sudden they are managing their illness better and they're avoiding complications from their diabetes.
Right. Mr. Algie, would you kindly comment on the issue of reducing costs without having a negative impact on care?
So I think what I'll say will generally be a repeat of what's been said before by the other providers in the group. So I'll just give another example of an instance where we did that. A diabetic patient we had who wasn't really compliant with their meds, was not diet compliant, was ending up on our ED pretty consistently. Again, hooked them up with care management. In this instance, it wasn't so involved in the process, really, the care manager. The care manager really became a cheerleader of sorts for this particular patient and really convinced them that they could take charge of their life. They could take charge of how they were managing their health. So we got them back into keeping their appointments. They were back on their meds and sort of on their diet. But the good news is, so that happened end of October, and the patient hasn't been in the ED since January in 4 months. So that's direct cost savings. And it's great for the patient because at the end of the day, nobody wants to be in the ED.
All right. How can the quality of healthcare provided to patients be assessed? Assembly members, do you want to start with that?
I'm not sure there is a good answer to that question, or at least maybe not yet. The head of the Aetna insurance company years ago, I don't know if he's still the head or has passed on, was famous for saying, if you can't count it, it doesn't count. A statement that always made me break out in hives, because there are a lot of things in life that maybe you can't count, but that doesn't mean they don't count. But also people in healthcare say a lot that whatever you choose to measure, that's what people are going to make sure they deliver. If doctors get paid more based on what percentage of their patients get their blood pressure checked, doctors are going to make sure that everybody gets their blood pressure checked. They may not get some other things checked. So you do have to be careful and thoughtful about what it is you choose to measure and what kinds of incentives you choose to apply. And again, that gets me back to the notion of it really does matter what master is being served and who's doing the deciding about what's going to get measured. Because if it's an insurance company that is paying the care manager or doing the deciding of what counts and what gets rewarded, it's going to be for what ultimately benefits the insurance company's stockholders. If a group of healthcare providers are doing all of that, yes, they have a bottom line to focus on, and they're human like anybody else, but they're also people whose function in life and whose friends regard them as a success based on how good they do at providing healthcare and not how good they are at increasing market share or their profit margin. And I think that really does make an enormous difference.
I want to welcome Senator Espaillat. Senator, I want to go back a few questions for you. Question number one is, what are the changes in the way the healthcare system is addressing the needs of persons who qualify for Medicaid, Medicare, patients who are uninsured, or patients with low incomes? Did you want to address that?
Thank you so much for inviting me, first of all. A disclaimer, I am not KSR. I defer to Assemblyman Godfrey, who really is, I must say, a true expert, right, in healthcare in general. And I think he's, how long have you been the chair now for?
Oh, it'll be 29 years.
29 years, right? I think I didn't speak English back then, but that's okay. So no, he's really an expert, and this is a very sort of like tough issue because it's very complicated, it's very technical, it's very legal, it's very difficult, and so financially and otherwise in terms of the ethos of it, right? And so the Assemblyman has been a leader, so very often when I have a wild and crazy idea, I go to him and he tells me, calm down, it's not this way, it's the other way, and so I listen to him. But let me just say to you that to some degree, I got involved in public service and in politics eventually because of healthcare. And through my grandmother, God bless her, who was the first one for my family to come to the United States, was a seamstress. She made it her business to ensure that I went to the hospital with each and every one of her friends to interpret for them. I used to cut into my Saturday baseball time. I hated it, but you know, she forced me to do it, and I got to realize that there was a problem because the healthcare. And let me give you an example. Right? In Spanish, the number 11 is once, O-N-C-E. That's 11. It's 11. 10, 11. If you read it in English, it says once. So if your doctor prescribes one pill per day, once a day, you may take 11 of those if you don't understand what it's saying, right? Very practical, right? And so I was a strong proponent of translators in the hospital. I said, you know, if you get arrested for a misdemeanor or a felony, and you go to court, the court system is mandated to provide you, the defendant, and we're trying to push also to provide the victim with translation services so they understand what the proceedings are. But when you go to the hospital, when you go to the emergency room, you don't necessarily have that kind of service. In fact, very often, the hospital resorts to a total stranger that was in the hospital room, in the emergency room, and that total stranger is now going to be privy to very private, confidential conversations between a patient and his or her doctor, or a family member, a minor, who may now have to go with his mom, or his mom may have to have a conversation that's not too comfortable with the doctor, and now the kid is going to have to translate for. So, you know, I was very. Eventually, the city put this Blue Ribbon Commission, and through the Health and Hospital Corporation, who are here today, didn't have a good day, right? Provided this protocol to deal with translation. This city is an immigrant city, continues to be. Close to 50% of its residents were born or are first generation New Yorkers. And so this city still has issues with language proficiency. It shows itself in the classrooms, it shows itself in the hospital, etc. So that's a real problem, I think. The other problem that I detected was that the situation is really, really, really bad. Even in a hospital as sophisticated and professional and high-tech and teaching as New York Presbyterian Hospital, which really owns the island. They split the island in half. New York has the southern part, Presbyterian has the northern part. And so I went to the emergency room to visit a friend of mine, and when I got there, I tell you with all sincereness, it felt like I was in an emergency room in the Dominican Republic. And people just, like a lady in the back, literally in the back, just got up from her stretcher and said, "Hey, Español, you gotta help us." And nurses and workers pulled me to the side and said, "Look, you gotta do something about this. This is just out of control." And there were like literally patients in the hallway and people in just chairs with IVs on them. It was a horrendous situation in a hospital where amazing things happen. Right? And so I said, look, we have to do something about this. I went to the guy and said, the wait period in the emergency room is out of control. So what are the issues behind how long you wait? Staffing is one, right? The nurses were in the middle of a contract fight with the hospital. Even lab techs are, you can be as quick as you can, but if the blood work, I know the Presbyterians here, I don't mean to beat you up. If the blood work is held back, right? Because you only have 2 lab techs, and I know that they're trying to motorize and change that, then that backs up the whole process. The number of doctors and assistants, so it's really a staffing issue. Now, Presbyterian since then has opened up a fabulous new wing, a new emergency room, if you may, that has also with it a unit to deal with Ebola and those issues, right? And then it has, they're making a clear effort to put capital dollars where it counts so they can have the infrastructure and deal with this issue of emergency room service in a neighborhood where you have probably one of the highest percentage of Medicaid patients in perhaps the entire city, and a good number still of perhaps people without insurance. And so, we began to talk about an emergency room clock wait time. Some states or some hospitals have it. So when you walk in, when you walk into the subway, you see how long it's going to take you to wait for the 1 train. It's pretty accurate, actually. There's no reason why you should not be able to walk into an emergency room and figure out how long is your wait time. That's, I think, a fundamental right that a patient should have, especially if you're in pain. And so we talked about that, and we talked about, I introduced legislation about that, and we talked about, and the nurses finally finalized their contract with the hospital, and I think they have an increase in staff now, to the hospital's credit. And there's a new ER rule, but we need to do more because I'm still getting complaints, right, people that are waiting, but I think we're doing better in that. The other factor that I think is important, and let me say that the bigger picture is that healthcare cost was really an important factor in the economic troubles that we as a nation had. Because the cost of healthcare had ballooned to such a degree that if you got sick and you didn't have any insurance, you lose your house, a month in the hospital pretty much wipe you out. And so that was Obama, I think, recognized that the cost of healthcare, in addition to some of the risky behavior that we had down in Wall Street, was also an important factor to tackle with regards to not only healthcare provision, but the state of the economy. Right? And so as a result, I think that the Obama administration put together this RIP, which I think is a great initiative, which is giving the state, is it 7.8 or is it over $8 billion?
About
$8 billion. And so there is a process for that, right? Of applications. And now applicants could apply for this funding to help reduce the hospitalization rate, unwarranted hospitalization rate, by 25%. What does that mean? Well, if I bump my knee and it hurts, maybe I can wait till Monday, on Saturday, right? I don't have to necessarily go to the emergency room. Maybe I can go see my primary care physician or somebody else, a specialist, right? I don't have to go into the hospital necessarily and backlog their process, and then somebody comes in with a real serious illness and everything is jammed up. Right? So we have to educate people. We have to do preventive health care. There's a whole gamut of things that must occur for this goal of reducing by 25%, which is a tough lift, right? Because reducing 1 out of 4 patients, that's a serious challenge, right? But there's money behind it. So the hospitals have applied. There's one group of physicians, local physicians that have applied. I think the great mistake in this area, or not mistake, but I should say the great problem with it is that the applications did not fully include the participation of community-based decisions. So the application has great goals, but the physician base, the doctor that my mom goes to, was not included necessarily in a fashion where he or she will have making powers within the structure itself, or where this whole ship was going. And that's why one group of doctors that belong to an IPA, Individual Physician Association, decided to apply on their own. So their application, I believe, was bottom down as opposed to top down. And I think that that's the approach for district. You got to have really a network. That doesn't mean that the hospitals don't have very altruistic goals and objectives to get to that 25%. I think that, they're all doing their best to do that, but we have to make sure that the primary care physicians, that obstetrician, gynecologist, that the cardiologist, that the doctor that's going to deal with diabetic, that the doctor that's going to deal with hypertension, with a Latino male like me, 35 years old, that has bad eating habits, stuff like that, right? There really has to be an effort to get to that so that we can get to that goal to reduce the patient flow by 25%. And I think that this case, New York Presbyterian is doing, I know, a good job at making an effort. They put together an advisory board that includes the doctor. My office is going to be going to those meetings. But I think that's a very tough goal to reach, but we can do it. I think we can do it, and there's funding connected to that. And I hope that the funding is spent for the right reasons. I think that I have addressed to some degree, right, some of the issues that impact people of Medicaid recipients, and there's another source of issues, a whole bunch of them that have to do with Medicaid reimbursement and the likes, but I didn't want to get into everything. Thank you so much.
All right. We were in the process of talking about assessing the quality of healthcare, but I just want to give Mr. Algie an opportunity to reply.
So again, we talked, what's measured is what we go for. I think there's plenty of measurement. I mean, we have more metrics than we really know what to do with. So there's a significant effort made to do that. The ACO has a set of measures. District has a fairly exhaustive set of measures, each one per project. And then again, the Center has the overarching goal of a 25% reduction in unnecessary EDUs and unnecessary emissions. So I think quality from a clinical perspective, I think that the clinicians feel comfortable that there is a set of measures that they believe have value, and I would always defer to the clinicians. And so I think it can be, and it is in some situations. It depends who's creating that list and to what end, but I believe it can be.
Okay. All right, Dr. Swartz, do you want to talk about assessing the quality of healthcare?
So, Assemblyman Gottfried is right. You focus on what you measure, and I think earlier on in the days of quality improvement in healthcare, I saw that phenomenon. We were doing a diabetes project, we had a registry, we were putting things in the charts, and so you were so focused on that during the visit that were you paying attention to other things. But I think we are in a situation now where just about everything I do is getting measured. We have an incredibly huge set of metrics. But I will say that's a good thing. No matter how well-intentioned a physician or a health system is at improving quality, if you don't measure it, you can't improve it. So that's a key enabler in sort of the science of quality improvement. And there's no question that if, for example, one of the common metrics is have my diabetics been immunized against pneumonia? And if that rate is 55% and I move it up to 90%, well, I've prevented quite a number of pneumonias in that population. That's an important thing to do. So.
All right, unless any of the other panelists want to say something special about how can the quality of healthcare be assessed. I'd like to go to the next question, which is where can patients go to get high quality care? Senator, you want to start with that?
Well, that's a tough one, but let me tell you what I hear from physicians, right? And I may agree with some of them, and I may disagree with some of the issues that they bring up. Some of them feel that they should go back to a fee-for-service model, right? Because some of them are capitated, right? And this is something that I learned. I'm not an expert in it, but in the process, I learned a little bit about it. That means that they get paid. They're capitated means that they have 200 patients and they're going to get X amount of dollars. And you correct me if I'm wrong, anybody feel free, for each patient, whether they see them or not, right? And so that they are, in some ways, they're going to get paid, and their incentive is not to have a patient get really sick and wind up in the emergency room. So there's going to be an effort from them to really reduce the risk for the patients to happen, for that to happen. And so they capitated, they're going to get X amount of dollars. I don't know exactly how much it is. It may be $30 per patient, something like that. So that the patient will stay healthy, they will not go into the hospital, et cetera, et cetera. So some of them believe that they are practicing defensive health care. Means that if someone comes in with a chest pain, and they feel that many of them, I think probably all of them, feel that there needs to be tort reform, right? And that the liability issue is a real issue, right? So if you come in with a chest pain, they're gonna have to run the gamut of tests for you, because God forbid they don't do an electrocardiogram on you, and the next day, when they release you or when you go home, you get a heart attack, and then you get hit with a malpractice lawsuit because you didn't follow the full gamut of potential tests that you need to have to take care of the patient the way you should. So they're practicing what they say is defensive healthcare, right? And so they're saying, I need tort reform. These liability insurances are really crippling us. In fact, not many gynecologists, obstetricians in the neighborhood, because the cost of that insurance policy is very high. And so I think all of that, right? It's really hurting. I'm not saying that I'm for tort reform. I have my own opinion on it, and we could discuss that at another forum for a whole set of reasons. But I think that all that is really hurting the quality of healthcare provision. I think that we should be more preventive-oriented education, preventive healthcare, and I think that we can accomplish that with this group.
I think it depends a lot on your financial resources. I think the healthcare providers serving this community are, on the whole, a pretty terrific group of people. Our hospitals are certainly our community health centers, individual practitioners. About a year or so ago, I had a wisdom tooth pulled. Actually, in my whole life, I only had one wisdom tooth. It eventually had to get pulled. My dentist referred me to an oral surgeon who did a magnificent job. I almost can't believe what an easy experience it was. Gave me a bill for $1,200, which thankfully I was able to easily pay. An awful lot of my constituents could not do that. My public employee health plan, because this oral surgeon was out of network, paid me $56 towards this $1,200 bill. And my thought was, there's probably a dentist somewhere in town who would have pulled my tooth for $56. I don't think I would want me or any of my constituents going to that dentist. And so part of the question is, what are your resources and who is paying for your health care? sort of a tongue-in-cheek answer to where can you go for quality healthcare is, well, you could start by moving to Canada, where nobody has to worry about financial barriers to healthcare. In New York, an awful lot of us do. Many of my constituents, no matter what, whether they had no health plan at all, would have no financial barriers to healthcare because they don't have financial barriers to almost anything. But the vast majority of my constituents do not live that high on the hog. So that is a real concern. A third of households with health coverage in this country report having in a given year at least one member of the household going without needed health care because of cost. And those are long-standing and worsening statistics. So that, to me, is the biggest obstacle to quality care, the financial obstacles to quality care, and the financial obstacles to providers being able to put in the time and effort that they would want to do if the way they were paid allowed them to.
Dr. Schwartz?
So I guess I'll reveal my bias that I think that the best quality of care comes from having a primary care provider with a strong specialty network behind you. We're also a federally qualified health center, the Ryan Network, and I think that our mission is to take care of patients on Medicaid, patients without insurance, low-income patients, and I think that you can feel that mission when you walk into our offices, whether it's the type of doctors that we attract, because that's the kind of services they want to provide, and that flows down through the staff. I'm sure you've all had experiences. I've had experiences with my own family members of seeing a competent physician who's not respectful or not listening to the patient. And that's another really important aspect of quality, that you're able to connect with your doctor and feel that your doctor cares about you and what you're doing. So yes, there are a lot of quality places to receive care in New York. I do think that particularly for patients with multiple health conditions, to have a primary care provider who's able to pull that all together for you, is able to have good communications with specialty providers in the hospital is important. One of the most important aspects, I think, of DSRIP, and I know that a lot of the year one DSRIP money went into this, is building electronic infrastructures so that I can get information from the hospital records, and in the emergency room, they can get information from my records. That kind of connectivity and knowing what's going on with your patient is critical if you want to provide quality.
Mr. Herbst, do you want to comment? And also, the issue is, let's say for the sake of argument, that federally qualified health centers are the way to go. There's not an unlimited number of them, and there's not an unlimited funding source, so then what?
Sure. Well, let me answer the first question first. I think high quality care, we need to define what high quality care is. First, you can try to say there's high quality treatment or there's high quality care. My personal preference is for there to be health care, not health treatment. Defining what that is really going to be requiring us to look at health and the delivery of health differently than how it currently is. The way I teach my students is that there's this triangle. You create access, cost, and delivery. If you change one, the others are going to change. But what we're trying to do now is we're trying to give access and not require the cost to go up and the quality to go down. You want to be able to have quality and still have it be affordable. You want to have access for everyone and not change the other evaluations in terms of the triangle. I had a chalkboard, I put it on the board right now, and I just crossed things out. But anyway, that's really how we have to define high quality care. In terms of FQHCs, community health centers do exist throughout, whether they get direct funding from the federal government and get an FQHC status or FQHC lookalike status, which is where a lot of public hospitals and other institutions are trying to move towards right now. Federal dollars and an FQHC will flow directly from the federal government, bypassing the state in many respects. That requires us, from a compliance perspective, to have different kind of regulation and requires us to have different kind of measurements in terms of, going back to the other question, assessing that. But there are other community health centers out there that really are on the ground. And from a cultural perspective, like the senator said, his grandmother received health care. You want to make sure that we are culturally sensitive. So an FQHC, a community health center, is on the ground. They're really empathetic to understanding the cultural needs. If there are issues with respect to people from different kinds of backgrounds, if you have a provider or an institution, a community health center, that's able to understand what that culture or that community is really dealing with, then we can really get to that primary, the preventative care much sooner, get them out of the emergency room. Let's get ahead of the curve here. That's why community health centers play such a vital role in the safety net. I go back to the safety net provider. That's really what a safety net provider is. It's really trying to get ahead of the curve and being a primary care provider. So we understand the cultural needs for the particular community.
Thank you. Mr. Algie, do you want to talk about this from the perspective of the hospitals? Also, can you tell us about community health care and population health, since I think these are some of your specialties?
Sure. I mean, just FQHCs do fantastic work. I just like to think we do fantastic work equally. Also, I think there's lots of great places to go. We have 14, many of the same things. We have 14 primary care clinics integrated with 50 specialty clinics, all on the same medical record. The clinicians, I do agree, they choose to be there, and I think it attracts a certain type of doctor who makes that choice. As I said before, we're the third largest Medicaid provider, so most of the patients we serve in our clinic system are Medicaid, Medicare, or uninsured. So I think there are places to access healthcare in New York that we've just ran through. They have a common theme of how they approach it and how they're trying to do the best for their patient. I agree, not just in treatment, but in care, and that's really a focus that we try to take on every patient who walks through our door. I mean, I think on the community and the population health, so the community health, it's a lot of what we talked about is community-based care, not in the hospital. I mean, it's really moving the focus of care out of the inpatient setting and putting it with the primary care physician. As well as, I think a team now is much more of an approach, a team inside the practice, because the front desk person might know something that really is important that the patient will share with them on a daily basis. It's important for the clinician to know. So we do team huddles in terms of how we need to take and treat our patients, as well as working with community-based organizations and collaborating around those social determinants that I spoke about earlier. On the population health, there's you can divide it by geography, a neighborhood. That's sort of the public health way of looking at it. Population health can also be driven by the payer. We've been attributed 30,000 Medicare patients for our ACO. That's a population we're responsible for. District, we have 87,000. That's a population we're responsible for. So I think there are various ways to define the population, and then it's really taking accountability for the health care of that group of patients.
Dr. Swartz, do you want to talk about community health care and population health?
Yeah, I think, I guess from my perspective, population health means moving outside the walls of the exam room. So, as I think I mentioned before, for many years, we were focused on who happened to show up. And the people who weren't showing up, we weren't paying a lot of attention to. So population health is really about knowing that you're responsible for a patient who should be coming in for care but hasn't. So how do we get that patient, get them in, and then get them to engage in care? And it also means following up on patients who may not be doing well. So that if we're concerned about an asthmatic who comes in with an attack, are we on the phone with that patient in a day to see how are you doing better, as well as managing care transition. So for me as a provider, it's meant moving my focus from not just the patient who's in front of me, but to this group of patients that I'm accountable for.
Okay, I want to combine the last two questions, and I'll ask every panelist. What are the panelists doing to assist patients obtain the care they need? What should elected officials and others do to assist patients in obtaining needed care? I'm going to start with the senator, then go to the assembly member, then I'm going to go to Dr. Schwartz, then Mr. Herbst, and Mr. Alger.
Thank you. That's a very sort of like complicated question. If you had the answer to that one, it would be much better. But let me just say, I started with the translation services. Right now, they're in regs, right? They're mandated by New York State Health Department regulations. They're not codified. They're not in law itself. So the bill that I have that is still around probably must be there for 20 years now, because when my first year I put it, so I've been pushing for it. It's to codify it, to make it an actual patient right, to ensure that they have that right. And I think that's important to improve so that services are linguistically and culturally sensitive, right? The other stuff is that on the ground, what I'm hearing from, and I think we all agree on the primary care physician model, right? That I had a meeting with a group of doctors, and there was most of them were specialists. There were 2 primary care physicians there. And so their complaint was that they're sort of like the traffic cop, if you may, right? And they were just overwhelmed. And they're telling me that they're spending like maybe 10, 15 minutes with the patient, and they're like bombarded with the number of patients that they're seeing on a daily basis. And so that has to be addressed. I think that has to be tackled so that these primary care physicians, who I think are the center of the model that many of us agree really works, could provide a little bit more quality time with the patients that visit their practices.
Almost every problem we face in health and healthcare, as patients, as providers, as employers, as taxpayers, is made worse and harder to solve because of the fact that we have a healthcare system that is financed on the model of insurance companies. And that's true not only in the commercial coverage world, it is now true of almost everyone in Medicaid, which is almost entirely privatized to be delivered through Medicaid managed care companies. Because of that fact, we face rising costs. We face not only rising premiums, deductibles, co-pays, restricted provider networks with insurance companies that tell us what doctors and hospitals we can see, and even what healthcare they will allow your doctor or your hospital to provide if you expect them to pay for it. As a result, we have patients with financial barriers to care and not getting the care they need, or wrecking their family finances to get it. We have providers who can, healthcare professionals and hospitals that struggle to survive financially and that can't provide the degree of service that they know they should and want to, or if they do, like with the City Health and Hospitals Corporation, it drives them to the brink of bankruptcy or over that brink. It is funded without regard to ability to pay, and because the insurance company wants the same premium, whether you are, Michael Bloomberg or the janitor in his office building. So it's a major contributor to income inequality. It does not have to be that way. We could take insurance companies out of the picture and have a universal, single-payer, publicly funded health coverage system. It's not going to happen at the national level for an awfully long time. But fortunately, we're a country where individual states have long been what they call the laboratories of democracy. And there are states like New York whose politics are much more progressive than the country as a whole, where I think we can make this happen. And to me, that is the single most important answer to every question that we've been talking about tonight.
Dr. Schwartz.
So starting with what we're trying to do, I would say there's a few things. One is we're outreaching to patients, as I mentioned before, and so trying to bring patients in for care. We have some collaborative relationships with the managed care organizations who will place someone in our practices. There are many patients out there who are actually eligible for Medicaid and don't know it and haven't signed up for it. And we're able to help them get insurance. That's important. And lastly, we're trying to improve access. So if you call up because you're sick and you hear, oh, sure, we can see you in 7 weeks, that's not very helpful. So we've instituted same-day appointments in our practices so that we reserve capacity every day for people that are sick and need to come in. From the government point of view, I'd say double amen. I really hope I could see that in my professional career. Short of that, I'll just share one of my pet peeves with the ACA. Although I think this was the most important piece of legislation in my career and has done a tremendous amount of good. And I think New York State has done much better here than many other states. But in many states, the low-cost, high-deductible plans, which is all some patients can afford, are exactly opposite the goal of the ACA. If you're a low-income person, just high enough to not be on Medicaid, and you have a $5,000 deductible before your plan kicks in, you're going to do everything you can do not to get care. And I just think that is a real problem with the way that piece of the ACA is designed.
Mr.
Personally, what my agency has done most recently is we've expanded. We continue to expand. We are in northern Manhattan, and we continue to move up top of Manhattan, top of the island, continue to provide our services, whether it's primary, dental, or behavioral health. What we also have done is we've instituted a women's health clinic where there was no clinic for many years. There was this gap. It was there for many years, and I'm not going to name institutions, but it disappeared. And for the population up in northern Manhattan, these women who one day the institution was there and the next day it was gone. So we saw this as a tragic consequence of politics within institutions and whatnot. So we decided to act, and we instituted this women's health clinic. And now the women do not have to go to the emergency room to get this type of help that they were otherwise receiving many years ago. We also provide ancillary services. We do quite a bit of translation at the community level for a lot of our patients. We also provide transportation for those people who are ambulatory or need ambulatory type of services. So we're really working on the ground to make sure that as a safety net provider, no one is going without coverage, regardless of their ability to pay. We're on the ground trying to provide these type of services, and we're expanding. And we're currently expanding right now. If you come back next year and we have this conversation again, hopefully I'll be able to provide some good news about our expansion if there's some northern Manhattan. We also have, like I mentioned, we're doing a lot of supportive housing. And supportive housing is a hugely important aspect in terms of the overall health of people in the city. Supportive housing, we work with people who would come from the shelters or would be homeless or would otherwise be coming from institutions. We get them out of the institutions or off the streets or out of the shelters, and we provide this type of housing where we can work with them through our social workers on staff, our psychiatrists on staff, and we put them through our services. And each level, the supportive housing, they are able to ultimately live independently. That marries itself very nicely with our health center and our services at the health center. So behavioral health and preventative health services go hand in hand. So if we can work with this type of population and make sure they receive this, then we're trying to get them out of the emergency room. In terms of the other...
I have to interrupt
Sure.
you. Thank you. Mr. Algie, you want to comment? And then we're going to go to the board members.
Sure, I would say that from the provider side, it's pretty much the same playbook of outreach, access, and then doing whatever you can to have people get access to coverage. So an example of outreach work we've done is we've done targeted health fairs for taxi drivers, bodega owners, beauty shop folks. Many of them work so many hours that just really don't have the opportunity to access healthcare, don't think about it. So in those opportunities, when we have them with us, we screen, we try and integrate them into a primary care setting. We generally do it partner with our our managed care organization so that they can be there and do enrollment and sort of solve hopefully the coverage piece. And then access. And you have to have an appointment available. Districts helped us a bit on that front in terms of expanding some of our access and opening up more evening and weekend hours.
All right, we're going to go around the table, and each committee member will have the opportunity to ask one panelist a question, and then I'll open it up to the audience. So we have to be brief because we only have 30 minutes. We will hold one for people. Robert Espia.
I just want to, it's not a clarification, I just want to point out that where the conversation seems to establish a divide between the hospital and the FQHCs, doesn't exist. The tradition of the FQHCs is often a partnership between the voluntary hospitals and the local community-based organization. In my particular place, my home is East Harlem, what we used to call the East Harlem Tenants Council. It's now called the East Harlem Council for something. And that's the Bodigan Neighborhood Health Center. That was launched by the Mount Sinai Department of Community Medicine. So it's a direct partnership, Dr. Juan Bosch. And the FQHC is a national model. There are hundreds of them across the nation. And they have to fulfill a certain level of performance and certain services that have to be offered. So that it's all done in partnership. When I went into North Central Bronx Hospital, I was the first director of community relations when they separated, when they closed Mount Sinai and Fordham Hospital Center. And Bob Massett, who was the chief of community medicine, was well underway with the establishment of the Montefiore network of community health centers. Several of those were FQHCs. That's where I believe I met. I think I met the assemblyman sometime before. So that the major hospital facilities were the launches in many cases of this entire system of the FQHCs, which is so important. And I think that relationship exists today. I hope it does.
Thank you so much. Sheldon Fine.
Okay. Question is sharing health information from one network or institution to another. I'll give you an example, and it's personal. I came out of an operation on bicep tendon at Beth Israel when it wasn't Mount Sinai. I went home, I passed out because of something that wasn't done. I ended up in emergency in St. Luke's. They tie me up to everything under the sun, give me morphine, and I'm in the emergency room, and it looks very like this is the end. Fortunately, my son was able to come. He must have run across the river, okay, and then ran up Broadway. And he says, I have the same thing too. Right branch, right bundle branch, which 20% I think of the population has. And they were treating me. Why? The reason they were treating me that way is because Beth Israel wouldn't send Mount Sinai my pre-op EKG. Fortunately, we have a friend who's an administrator, and so my wife called him, and he got them to fax it, and they saw it was identical. But they could have killed me that night because they wouldn't share, and now they're part of the same network. So my question is quickly, does for those who are practitioners, do you share information with other networks, and is it electronic? And for the elected officials, do you think there should be something in law requiring them codified, as you said before, that they can't hold back information because I could have died while I was waiting for this problem? By the way, it happened again about half a year ago.
All right, you want
to
I think that that's a real challenge for all of us. I'm not going to say there's an easy answer. The hope was that the Rio would be the solution, that we'd all be able to upload, and that would be the connection across. I think we're connected to the Rio. That's part of what we want to use district dollars for, is start to connect all providers to the Rio. The consent issues are really problematic in terms of the Rio, because if you consented to share at Beth Israel, but you didn't consent to share at Mount Sinai, then that connection can't be made. So I think there's challenges on it, but we're all working towards it.
Okay, first of all, a little bit of translation. Rio, Regional Health Information Organization, It's the network sponsored in part by New York State, but also organized by the healthcare providers around the state to share electronic health records from institution and provider to provider. There are a lot of regulatory issues that need to be sorted out, as you were saying. If I've consented to give my information to my doctor, does that mean that some hospital has a right to get that information when I walk in the door? If they don't remember to have me sign papers consenting to the downloading of that information? And what if I'm a minor who can see my information? But New York is fortunately moving well on its way to having a very robust system of both use of electronic records and development of regional interoperable systems with a lot of protections for individual privacy. One of the things I've done as chair of the health committee is try to make sure that that whole system is publicly accountable, and providing public funding for the development of it is part of the way that we are keeping a public interest hand in the development of that system. There are countless stories of people whose lives have been saved because of that kind of information.
Senator, I know you have to leave, so if you have a comment, please.
Yes, I have a comment. First, I agree with everything that the assembly member said. Second, I think that it is a cost-effective strategy because it will drive down costs, because it will reduce the duplication of tests and unnecessary services. But also, I think not only to think nationally and regionally, we need to think globally, right? Let me tell you one of the reasons why I say that. My district, many folks retire and they go back to Puerto Rico, they go back to Mexico, they go back to the Dominican Republic. Many of them purchase a home, retire there. They have several health conditions. Some of them are widows, some of them already lost their partner, and they're abroad and they come back and forth. They really get sick. They have to fly back to the United States, and very often they get sick because their physician is back there and not privy to the information that they need to have regarding their healthcare practices. And so when they come back, because they get very sick, they really have to come back and stay here. And then that presents a whole host of other issues. What happens to the property they have back there? Sometimes family members or people that are caring for the property take over it. So it's really, we need to think globally about this, right? How do we provide healthcare nationally and globally, but definitely by sharing this information, it's a good healthcare practice and a very cost-effective tool. And I think we can do more to bring about.
Thank you, Senator. I know you have to leave. Thank you for squeezing us into your busy schedule. Not done yet. Let's say goodbye to the Senator. Christian Jerry Cordova.
I have a concern with the cost of insurance. Prior to the Affordable Care Act, I was paying a level of insurance and care. And after the Affordable Care Act came into effect, my insurance went up, my cost out of pockets have been higher. And I wonder whether is this something that everybody's experiencing, or and what can be done about it?
Well, it's hard to answer what the cause of the increase in your premium was without knowing a lot more about the kind of coverage you had before, why you have the new coverage. I think a large part of the problem, as I said earlier, is that the Affordable Care Act, while it has improved a lot of things for a lot of people, it leaves us in the hands of insurance companies. And every time we try to enact a reform in the insurance world, their lawyers are at least as smart as our lawyers, and they figure out new ways to do us in. And our system rewards them for doing that. We created exchanges in which you can go on your computer and see, compare one health plan to another. And while there's a ton of data there, everyone inevitably focuses on one piece of data. What's the premium? And they don't focus on, well, what's the deductible? They don't focus on how restricted is the provider network. And then they find that they've paid a slightly lower price for coverage that they can't afford to use. And that's inherent in our system until we change that system. And the New York Health Act that I've been sponsoring to create a single payer system, I think really is the one essential thing that we need to do.
Okay, Catherine DeLazaro, co-chair.
Audrey, I have a very specific question about care in hospitals, especially when people come to the emergency room. Part of what we've been talking about in terms of people receiving quality care is kind of access to the care, and part of it is reducing error and mistakes and harm. And I think central to that is the consent process when it comes to procedures in the emergency room. Because this is only anecdotal, and I don't know that my experience is universal, but I was hospitalized a few times a couple of years ago, and what I witnessed in the hospital, and I was in a great hospital in New York, and what I witnessed was just kind of this automatic CT scan, for minor things, that there was really no, when it came to procedures, these very high-risk procedures, I mean, CT scans are pretty serious. It seemed like if I understand correctly, it seemed like part of the reason for that was to avoid litigation for hospitals. And, there can be immediate or long-term harm from those procedures. And there was no, for me, and it seems from what I observed in the emergency room, there was not a lot of communication or ability to consent. And I'm very concerned about people who are very vulnerable, either because they're sick and so they're vulnerable, or English is not their first language, or there's a whole variety of reasons for why it's important for people to consent to procedures if they're awake. And I'm wondering if there's any work that's being done around kind of consent for procedures in hospitals.
To whom are you addressing the issue?
Anyone.
Can you pick one person?
Who feels able to answer that? Maybe you can because you're a...
From the hospital, right?
Yeah.
I mean, consent is always a very necessary and actually legal part of what we have to do for any procedure. I don't think CT is viewed as a procedure. I think it's viewed as a diagnostic, which is generally why there probably was a consent on that. I think there's an ever increasing awareness of not in that specific instance, but of the radiation load over time and doses like that. There's being greater and greater sensitivity to that. I know, but just in terms of consent procedurally, we have to get consent. We have to provide translation services. Obviously, if if a patient is unconscious, those decisions are going to be made, but again, they're going to be made in the best interest of the patient. So I think, again, speaking only for our hospital, we're going to try and do the best thing we can do from a patient care and a patient experience point of view. And I don't think that would include doing something without a patient's consent.
Co-chair Madge Rosenberg. I'm a little confused, and I think this question is for Mr. Herbst. First of all, is Heritage a nonprofit?
Yes.
And what is your relationship to the managed health provider system? And is that synonymous with an insurer? What is the difference between an insurer and a managed health provider system?
So let's untangle these terms.
Yeah.
So first of all, my organization is a nonprofit. It's a requirement. Like I said, our requirement is that we have to have a majority of people in the community serve as our board members, so they're my boss. The community is my boss, and essentially it needs to be 51% people who use our health center to be people who run our health center. So that's what our organization is as an FQHC, generally as a community-based health center. When you say managed health, I want to make sure I understand, because managed health can be a lot of things. There's managed health. Yeah.
Well, if that term's come out, sometimes it says a managed
Sure.
healthcare provider.
A managed care organization, is that
Yeah.
what you mean? Okay. So an MCO, managed care existed, let me go back, and I want to answer actually your question by also answering the fiber question. I'll do it so by trying to combine the answer. We see in our new system of healthcare delivery, change from a fee-for-service and FFS to certainly now in the district, a value-based repayment. And under this BPP, we see that there is a new type of push away from trying to get people to just get tests for the sake of getting tests. And that's why we're not going to reimburse for the sake of reimbursement. Value-based payment is really going to require us to look at things differently. Managed care is along the same lines in terms of making sure that people get the type of healthcare in a group setting and moving it away from fee-for-service in many respects, changing the way that healthcare is provided. And that's what a nonprofit is trying to do.
Kathy Ancina.
This has been a very enlightening program. I came with a different question, but I'm going to move into the second question first, and I hope there's time for the first. And that is looking at the demographics of aging, and that the fastest growing age group here is 85 and above. And for people over 85 years of age, hospitalization can be very traumatic, especially for a person who's very frail, and if a person has cognitive loss. And going into the emergency room, for instance, an emergency room that's so crowded that family members are forbidden to accompany the relative. The elderly woman is there for 18 hours, not fed anything for 18 hours, not changed. Family member not permitted to even hold the person's hand and remind her where she is, because she doesn't know where she is and is just crying uncontrollably. So, and the next thing is then the person is eventually admitted after 18 hours, and the person who's supposed to accompany this patient, this elderly woman, to her room, rides her so fast, gleefully through the halls, while she's holding on for dear life and screaming, and he's laughing because he's able to now rush this elderly woman wherever the hell she has to go. When she finally arrives, the nurses say, "Oh, look at this one. She's as old as we've ever seen. Oh, look at this one." So I'm mentioning it because I'm sitting here thinking this is almost some kind of fantasy. I've worked in nursing homes to try to help make them humane and enlightened places for many years. I've accompanied many elderly people who were hospitalized and should not have been, when family members fought for hospitalization and lost because the nursing home insisted on hospitalizing them, the family member knowing it would be traumatic. And I would try to accompany and advocate for that patient and that family member. We talk about consent, nobody listens. You have to go in with lawyers and marshals. So I'm pleading with this group to really get real about the trauma toward very elderly, frail people, especially people with cognitive loss, and the fate that they suffer in hospitals is unbelievable, where everybody is eager to take their blood every 20 minutes as the person is screaming, and there's no need for it, really. When you ask for palliative care and they say, "Palliative care, you want to see a priest," thinking you're asking them to kill this person, when all you're asking for is compassion and kindness. You know, it's good that people have computers now to convey information, but the problem is the staff are so fixed on the computer screen that they forget the human assessment of the patient. So I'm sorry, I wanted to ask a quick question. I'm going to stop there and just see, does anyone want to comment?
We have to move on. We appreciate what you said.
Looking for comment from someone made on comment.
Well, I'll comment on it, yeah.
Thank you, someone.
You can't legislate that healthcare providers and others who work in institutions, you can't legislate that they not make jokes or that they treat everyone with respect and be serious, etc. It'd be hard to write a law that said that. And if you did, how would you enforce it? What you can do, though, is try to make sure that the people who work in hospitals, in physician offices, in community health centers, in nursing homes, work in a humane environment and work in an environment where they are not understaffed and overworked and where their employers treat them with respect and where there are enough resources for them to do a job that they are confident about. And those are things that we can affect. And I think we've talked about that a lot today. You know, one thing I've wanted to say in response to a lot of questions is I like to say, think about the fire department. Firefighters run into flames. They rescue people. They do work that none of us would ever be willing to do. Some of them in some communities do it as volunteers. They don't get paid for value. You know, if the building burns down, they aren't docked. If the fire went out earlier, they don't get a bonus. They aren't paid by how many fires they go to. And yet they run into fires every day to save our lives. And I think we ought to think about, why do they do that? And I guess we should be thankful that when Ben Franklin invented fire insurance, it was to pay for the damage and not to pay for the people who would come and put out the fire, because God knows what the fire department would look like if we had fire insurance companies that paid them to come and put out our fires. And if we weren't covered. But I think a lot of what we need to think about is how to keep making healthcare workplaces places that help to guarantee that we are all treated the way we all want to be treated and the way our healthcare providers want to treat us.
Thank you, everyone, for a very high-level discussion. I have these are two short questions. The first is, we know there's a shortage of primary care doctors in the country. And I'm wondering about New York. I assume it's the same way, but I've heard a lot of emphasis on primary care doctors, which I think is commendable. So if you could comment on that shortage. The second one, I think is prevention is often equated to screening. And if we're doing screening, then we're doing prevention. And I think that that is really very far off base, but I'd like to know your opinion. One person. One person. Well, how about Dr. She's in primary care.
First of all, yes, prevention is certainly more than screening. I will say that there are some screening tests that are prevention. My two favorites are the pap smear and colon cancer screening, because both are opportunities to prevent cancer, not to just catch it early. But certainly we're also looking at other preventive measures. I think the prevention that's been most difficult for us in our short office visits is really things like trying to help people to adapt a healthier lifestyle. It requires time with patients, and I think we really need the help of other team members around us to do that. There's absolutely a very strong prediction that we're going to have a worsening shortage of primary care physicians. And I think that can be attacked from many different levels. Certainly beginning to use more nurse practitioners and physician assistants alongside us, but really, it was mentioned before, patient-centered medical home beginning to function in teams. There's a lot of things that we do in office visit that didn't require an office visit, and then if we had a team member working with the patient. Outside of that, you could use me for the stuff that really requires no medical skill.
Yes, my name is Danny Perry. I work for Independence Care System. We're a nonprofit managed long-term care plan. I have a question pertaining to Medicaid. There are a lot of myths out there regarding people that are eligible for Medicaid or can become eligible. There are options such as like a pooled income trust allows people with excess income to still get Medicaid. My question is, what type of education are you seeing in the community to let people know about their opportunity to become eligible for Medicaid and receive the services that they need? And that question is to anyone on the medical side. Anyone on the Medicaid side?
Mr. Herbst, you want to respond?
So, what my organization specifically is doing is we are in the community, we're in barbershops, we're in supermarkets, we're in actually places of business where people congregate. We're telling them, new laws are coming out. We're helping educate, and we're, on the ground trying to tell people what they can do and what they cannot do. So a lot of misnomers out there. People are confused about a lot of these terms. We're even using acronym stuff here, and I'm not defining everything that I'm saying, and going to that last question. But education is really crucial, and that's why we're on the ground in places of business where people congregate, helping them understand what they are entitled to and what affirmatively needs to be done to get certain entitlements. We're also a school-based health center, so we're working with children, and as a school-based health center, we're in the schools working with children and their parents to help them educate as well.
My question is for the Assemblyman. I work at a company called ZocDoc. Some of you may be familiar, they have booked your appointments online. And I talk to providers primarily of all different specialties. And the probably one of the major issues I get is regarding patient education for Medicaid patients. So that's why I felt it was important that I be here today. So I'm curious about the drive towards education around your knowledge of insurance as it exists today. Single payer sounds very exciting. I am so down, and let's do it together, you and me. But what is it that we're doing to help Medicaid patients understand who their providers are, their assigned providers, how they can get a different provider if they want it? Does that happen on the ground? Does it happen via technology? And where can I fit and help?
Yeah, I'm not sure I'm the best person here tonight to answer that. I mean, what we in Albany, one of the ways I try to advance that is years ago when we were promoting the availability of an online way to enroll in Medicaid to make it easier for people to do that. We have a fairly extensive network in New York of nonprofit community-based organizations that are funded by the state. Getting that funding every year takes some doing to support people who are looking for information about the Affordable Care Act plans, about Medicaid, about long-term care, about Medicare, and to help them not only find plans, but then fight for their rights within their health coverage. There are a lot of healthcare providers, as Adam Herbst was saying, and managed care plans that go out into the community at street fairs and other things, and just at subway stops, trying to provide information to people. It is, of course, a constant effort because there are always new people coming into the community, and there are always new things that they need to be informed about.
This is the last question, Katie Robbins. Yes. Okay. Please address it to the particular person.
Sure. So my name is Katie Robbins. I work with Physicians for a National Health Program, and this is actually more of a comment. that, you know, I'm very proud of the progress working with Mr. Godfrey we've made on the New York Health Act. And we passed it in the Assembly last session with a huge majority support. And we have 22 co-sponsors in the Senate on this bill. We need 32 to pass and get it to the governor's desk. So there's been tremendous momentum. More and more organizations have signed on to this bill. I have a petition that I can circulate tonight so that you can sign on and make sure your senator is on board. But a saying that I heard once a few years back that really resonates, I think, you know, so many people here are so knowledgeable and working very hard on the system as it is to make it work for people the best they can. But really, it's when the people in the park and the people on Park Avenue are in the system together is when we'll have a high quality healthcare system. So I hope that people here who are interested will join us in pushing the New York Health Act. Thank you.
Before I turn the microphone over to co-chair Catherine DeLazaro, I want to thank each and every panelist. I know how busy all of you are, and you took your precious time to come here and join us for this very enlightening program. I want to thank the people in the audience for their wonderful questions. I just want to thank everybody who is here.
And thank you, Audrey.
Thank you, Audrey. These events are actually way more work than you could ever imagine. So we're so grateful to Audrey for planning this. And also Robert, who is going to be facilitating an event next month on domestic violence. So we hope to see you there. For panelists and members of the Health and Human Services Committee and the board, I'm going to be sending a survey to kind of ask you about your experience. It will be a great help to us if you would take the time to complete the survey. There's only 10 questions. I know it's asking a lot because you're busy, but if you have time, you'll be receiving that. And thanks everybody for coming. Just a question out of curiosity, how many of you are on the Community Board 7 listserv? So you're receiving notifications? Many of you? Okay, just curious. Great.
For those people that spoke, can you please just give me your names for the record and your affiliation?
And actually, if you can make sure that you sign the attendance list in the back before you leave. I saw only 1 or 2 signatures, just so we have your contact information if you want to be added to the list.